specialist does. So with California Bridge, we use the acronym SUN, Substance Use Navigator. And through funding, that's how our hospitals are hiring on additional staff. But I hear here in Montana, it's a little different. There's lack of funding. Some hospitals without funding just decided to hire a substance use navigator. Our definition of a substance use navigator, they can have a lived experience or have a family or friend member with a lived experience. So, because again, they have valuable experiences. So really, our definition is a little broader. And again, our sons are based in the emergency room. They live in the emergency room. So I'm just going to talk about that. One of the comments I really liked at the National Opioid Summit was the opioid epidemic will take more than one person and one profession. So there is room for coordination amongst all of us. And I just really wanted to say that. I live that every day. I'm still a SUN coordinator over at a hospital per diem. So it really does live within the substance use navigator or care coordinator. And what do care coordinators do? Well, our care coordinators introduce patients to the MAT program services. They develop those connections and provide follow-up for patients. And not only do they change the culture, they're the role model. This is where we were. Hold on just a second. So I think I was talking back with harm reduction. They are the role models in the emergency room. Some of these hospitals and emergency staff have not even been introduced. So again, it's kind of a mix between the peer navigator and a community. This is the middle. Our funding, really seeing a need to bridge that coordination. So that's what we do. They're a role model for change in the ED. They reduce the stigma and biases. They provide support to the ED team. A lot of times our sons are the go-to person. Hey, I have this patient, they're not opening up, they're not talking. Because that our care coordinators or sons, as I refer them to, they have that time to go and speak with that patient. And maybe they're scared of a test. Maybe they're scared, they're there for medical reasons. They have that training to know that I'm going to meet them where they're at. They may be refusing care. And our sons are trained not only in motivational interviewing, but to deal with the ED. Just in general, Amanda was great at saying people are overwhelmed in the emergency room. They're not listening. They're scared. They don't have any support. So being in the actual emergency room, meeting a person one-to-one is a great opportunity to make trusting relationships. And I really stress that sometimes these patients are not, it's not all successes. I'm not going to, I'm going to be very transparent. Sometimes it is a failure because the patient does not want our help or is not ready. But the care coordinator in the ED can make that lasting relationship and call in a week or two and say, hey, how's it going? Just with a follow-up. So they're kind of the in-between, again, bridging the emergency room to support. I like to say they're really not only a patient advocate, they're a cheerleader for our patients. They're telling the patient, you can do this. I'm going to be with you every step of the way. I'm going to help you. And really the biggest improvement that we've seen in the emergency room is collaborating with the treatment facilities and providing a warm handoff. Again, if I can pick up the phone and talk to somebody on the other end and give that warm handoff, hey, I have a patient for you. You're going to meet her. I'm going to send her to you. She has questions. Here, can you talk with her? It really speaks miles for the whole trusting. And again, patient involvement. The patient is part of the team, and we meet the patient where they are at without judgment. This has been probably the biggest challenge in the emergency room, is taking away all those biases. Our sons do not have that bias. They're hired with the intent that they are kind of given the confidence to know they are the role model for change. They're going to not judge the patient. They're going to, maybe it's just a harm reduction visit. Maybe it's just telling them, hey, we don't have a syringe exchange program, but here's some alcohol pads. This is what I can offer you. I want you to be safe. Here's some hand sanitizers. Please make sure you're washing your hands. Very important. That's what we do. Our training is just meeting them where they are at, provide a safe, confidential patient intake experience, not in the middle of the lobby, and just really building trust. And it's really a patient-centered journey. And we also will speak with the family. A lot of times, people will hide behind HIPAA and we can't talk. Of course, we can't, we're going to follow whatever the patient wants us to follow. They are the leader of this journey. And then again, assisting them with recovery. So for our substance use navigators, this is the workflow in the ED. And all of our hospitals have to kind of tailor make it to their processes and their systems. It's not just one size fits all. Everybody is aware of how their population and their workflow. This is just a guideline. And basically, the son meets the patient identified with SUD. Sometimes it's a call and the patient comes in and meets them in the lobby. The son consults with the provider for the MAT and asks, questions. Do you want MAT? Do you not? Those type of things, and just explains the whole procedure of what's going to happen. People are scared and they don't understand, or they might say, one of the things that's really been universal throughout all of our substance use navigators is patients that say, I'm allergic to buprenorphine. Our peer counselors and substance use navigators are great at telling them they probably were not prescribed correctly, not enough. Ariana and Dr. Andy King talk about, giving enough to get through the withdrawals and precipitator withdrawals. So that's something our substance use navigators and care coordinators can explain the system. We know you've had bad experiences, but this is probably why. And it's that cheerleading and patient advocate that can really make a difference. Facilitates treatment, again, connection to ongoing care. And we can do it 24/7. When you talk about, is it available? The buprenorphine, of course, is available 24/7. We encourage our care coordinators to have a robust referral system. That means having the exact hours on their voicemail. That means exactly telling them when the substance use navigator is there. Our patients are a very special population, and I can honestly say I still, work for them at my hospital, and they know that I'm going to be there Saturday mornings. So Saturday morning, I will have patients coming, patients call. So they're very, they remember everything that the sons tell them, or your care coordinators, because that's who they trust. So, I can honestly say, tomorrow, Saturday morning, I will expect some patients to come, because those are the relationships we've built. And some can work in the evenings. Ariana put in the chat that her son works 10 to 6:30. Weekends are great too. I know some of our sons. So it's really when the majority of the patients, I would say Friday to Monday is really our busy time, with holidays always being really busy. Mother's Day is a huge day when patients come into the ED wanting to change their lives. They're going to, you have those moments. So your population, what hours, and there is a pattern, definitely a pattern. So that's what I want to say about our sons or care coordinators. And so, like I said, they can be so helpful. Our state provided grant money for us to hire 52 originally in our first inception years, and now we're going for over 200. And then with another grant, we'll have every substance use navigator in every hospital in California. That's over 300. So, this has been an opportunity through grant money. Some hospitals are learning about sustainability and what they can do. Definitely that is moving forward, but like Bobby mentioned, it's still uncharted territory. We still have to follow up and find out where additional funding. Some hospitals have just decided this is great for our community, this is great for our patients, and they hire them. We also have some hospitals that contract with outside companies to bring them in. So there's several different options. I am a nurse, and I was, recruited to start the program, so I have a little more experience. And when we look back at what this position needed, an RN, a social worker, a person with lived experience, or that has a family or a friend with lived experience, it has to be somebody passionate, because you have to learn to talk to the patient in a different capacity, and that's meeting the patient where they're at, not telling them, like Amanda, they told her what to do. We don't tell anybody what to do. That's not the role. And I had to learn it. 25 years of nursing, it was very strict plans. This is what you do for this. This is what you do. That's what we learn. But talking to patients in a different way and just letting them know, hey, what is it? What is your goal? What is your goal today? Today may be just, I just came because I want to get on buprenorphine. I don't know if I'm going to take it, but I just want it in case. All right. So it's not, I don't want to say it's hard to learn. It's just really, again, self-reflection and learning your own personal perspectives of how you can become a patient truly advocate, meeting them where they're at. If you have naloxone distribution program, just say, you just overdosed. I want you safe here. Here's the box. Where's your family? Can I tell them how to use this? Some of them already know, but it's that this is the first time somebody accepted me as, as I am. Thank you. I've had some patients that have come back 3 or 4 times for naloxone. And that's okay. No judgment. We just have to move on. And, it's like, again, be a role model for the rest of the staff. So with that, I'm going to leave you. Do you guys have any other questions for me?
This is Dan Knotts. I thank you for an excellent presentation regarding your sons. What's clear to me is the sons are clearly part of an integrated team. They're part of your team in the emergency room and have been trained and are on board certainly with your program. And so that's clearly a clinical role. They're communicating certainly with the provider, they're communicating with the patient, and they're using motivational principles and working with that patient and hoping to encourage engagement with treatment. Amanda made it clear that what they're doing is essentially non-clinical. So I'm somewhat confused about that, because in some respects, peer support does do some. Yeah. Peer support does some of the same things, but by nature, it is still clinical work. So I'm thinking, I'm almost thinking we almost need something additional to the peer support to actually replicate what you're doing, or explore the possibility of creating a similar position as you're using in California. Really appreciate the way your folks work. Thank you.
Great. Thank you.
Can I speak to that real quick? So Daniel, I just wanted to say that we, based on the Montana state requirements, we have to say that we are non-clinical, while we do integrate throughout. So many of the things that Sherrie was speaking to in regard to their son's program, that is exactly what peer support is able to do in our state. We just cannot say we are counselors. We cannot say that we are clinical because we don't have that clinical experience aside from the direct lived involvement through those processes ourselves. So I just wanted to clarify that. Yes, we are an integral part of treatment teams, of care coordination, and we advocate for the voice and choice of needs of the individual. And we also serve as a bridge to help individuals understand why providers and other clinicians might be recommending specific types of treatment.